Good afternoon, and I'm rather hoping we're being joined by our colleagues from Scotland, Wales and Northern Ireland. So I'd just like to firstly introduce everybody who's here and say on behalf of them it's excellent to see all of you in person. Very nice to see you, and look forward to discussing questions subsequently. So I'm Chris Whitty, I'm the Chief Medical Officer for England. Here in London, Dr June Rain, who's head of the MHRA, the independent regulator. On my right, Professor Wei Shen Lim, who is the chair for the JCVI on vaccination, because we very much followed on from their advice. And we're fortunate to be joined by the CMOs of the other three nations of the UK, Dr Gregor Smith in Scotland, Dr Frank Atherton in Wales, and Sir Michael McBride in Northern Ireland. So thank you for joining us here today. What I'm going to do today on behalf of all the CMOs is lay out our logic of where we've got to, and then I'm going to invite Dr Rain, as the MHRA starts this process as the independent regulator, and then Professor Lim, who, because JCVI very much takes the next stage before we move on to views from my colleagues in the other three nations. So the reason we wanted to lay this out fairly clearly is this is obviously a difficult decision, which is the reason the CMOs were asked to take a view on this. And in all of what I'm about to say, I want to start from the first principle of medicine, which is it is always about balancing risk and benefit. And if by doing something the benefits exceed the risks compared to not doing something, then it is a sensible thing to do, and if it's the other way around, then it is not. That basically is central to all of medicine. There is almost no area of medicine which is risk-free. So what you're always trying to do is balance risk against benefit, and that's true in this decision as all other ones. When it comes to recommending vaccination for children 12 to 15, there are several stages we've gone through already before we come to what we've said today. The first is that the independent regulator, MHRA, has examined the data, and their judgment was that in all those aged 12 and above, for the messenger RNA vaccines, which I'll give as a shorthand as Pfizer and Moderna, that they authorized these for use and gave them a license at this stage in time on the basis of their assessment of the efficacy, how effective they are, and the side effects as understood from trials to date. So that's where they are, and of course they continue a process of continuing to look at both efficacy and side effects in due course. JCVI, the Independent Scientific Advisory Committee, then took that on, and they've given two very important, in a sense, adjacent views about the use of these vaccines in children and young people. The first of which is they have given a clear recommendation that for children and young people over the age of 12, who are themselves in a particularly high-risk groups, and they've given a list of those groups, or, importantly, living with people who are immunosuppressed, they recommend that people 12 and above have 2 vaccines with messenger RNA vaccines. So that is already a decision that JCVI has taken and that others have followed. Secondly, they have recommended that young people aged 16 and 17 get a first dose of vaccination, and that dose of vaccination is given to was offered to everybody. And that supplements the 2 vaccines that are offered to everybody 18 and above. So that is the current situation. On the situation of looking at children and young people aged 12 to 15 who are not in the high-risk groups, so their view on the high-risk groups stands, so what I'm about to say refers to everybody else. They looked at the risk and they looked at the benefit, and their view was that the benefits exceeded the risk, but that the difference between these two was, in their words, marginal. And that is because the risk is small and the benefit is small. The benefit exceeds the risk, but by a small margin. And by their usual assessment in terms of individual risk-benefit, their judgment was they wouldn't normally, in this situation, recommend the rollout of a vaccine. But to be clear, they did say that benefit exceeds risk. And I think it's important to start with that principle. They also, however, and very atypically, made a suggestion to ministers that because there were also wider issues at stake for children and young people of this age, that the ministers consulted the 4 chief medical officers. And that is what's happened. So ministers were following a suggestion of JCVI that the wider situation was that. So that's where we got to in terms of why CMOs were asked to do this. It was following a suggestion from JCVI. Now, in doing this, the chief medical officers have taken several principles which I want to lay out. And I realise this is a long preamble, but I really want people to understand this. The first principle is that we will only consider, and we have only considered, risks and benefits that actually accrue to children and young people 12 to 15. So we have not considered any benefits that might accrue to adults or anyone else. This is purely about children of the age group we're talking about. That's a first really important starting point. The second important starting point was we did not intend to, and we fully agree with, the assessments of MHRA as the regulator, independent regulator, and JCVI as the scientific advisory group. So we've not gone over any of their data again. We've simply taken it as read. And they've done a very useful table of risks against benefits for those who want to look at the numbers. And Professor Lim can talk about that if people are interested. But we've taken their numbers as read. The third thing we decided was we wanted this to be a central view, as best as we could assess it, of the medical and scientific and public health professions. And to achieve that, in addition to looking at data, which we have done independently outside the stuff that JCVI has looked at, we also consulted the presidents of the Royal College of Paediatrics and Child Health, of the Royal College of General Practitioners, of the Faculty of Public Health, and of the Royal College of Psychiatrists, looking at issues around mental health. And we additionally have consulted leaders in public health from around all the regions of England and Scotland, Wales and Northern Ireland. So we've tried to have a very broad view about where things come from. And I suspect when professional colleagues respond back, they will fully accept that what we're trying to do is get a middle view of where we think the profession is. So this is not an outlier view, this is a middle view of where we think the profession is at this point in time. So that's the preamble, and I just wanted to lay that out so that people understood the process. Now, in terms of our judgment, the starting point, of course, is JCVI saying there is an advantage, but it is marginal. So there is only justification for roll out a universal offer if the risks and benefits on the additional things we can look at are actually material. And in particular, we looked at education, which is clearly central to the consideration of anything for children and young people 12 to 15. And we also looked at operational issues. For example, how does this interfere with flu vaccination and other areas? We didn't go back over the clinical ground because JCVI has already covered that, and we fully agree with their assessment. And when we did this, we had some extremely powerful evidence, both numerically, but also from our colleagues working particularly in areas of deprivation around the country, and also general practitioner colleagues, and also colleagues from mental health. And they all made the same point, which is the disruption in education that has happened over the last period since March 2020 has been extraordinarily difficult for children and had a big impact on health, mental health, and long-term public health. And that this is most apparent in areas of deprivation. They were very clear on that. So the question for the CMOs on the educational side, accepting that advice, which completely concords with all the data that we have, was will vaccination reduce the disruption and therefore reduce these very significant negative impacts? And our assessment is the answer to that is yes. It will reduce education disruption. We do not think that this is a panacea. This is not a silver bullet. It's not a single thing that on its own will do so, but we think it is an important and potentially useful additional tool to help reduce the public health impacts that come through educational disruption. So that has been really critical in our decision making, and this is true whether we're talking about individuals, physical health, individuals' mental health, or the long-term effects that a disrupted education can have on people's life chances. So that's very much where a lot of our discussion lay. And we did think that on balance, it was likely to improve things. And we looked at the negative sides, and there are some issues around operational issues, as I say, particularly around vaccination. But our view was the benefits that this is likely to lead to in terms of reducing impacts on education outweighed those negative areas. So overall, our assessment is combining the marginal but assessed benefit that JCVI made at an individual level, taking on board additionally the issues around education. Our view was the benefit exceeded the risk to a sufficient degree that we are recommending to our ministers in all 4 nations that they make a universal offer, and I want to stress the word offer, of vaccination to children 12 to 15, in addition to the ones that are already being given it. So that is our current advice to ministers, and it is now with them to decide in each of the 4 nations how they wish to respond. Just want to add one additional thing, and then I'd like to ask Dr. Rain and Professor Lim to add from their sides and then turn to my CMO colleagues. And that is that we are really clear that it is very important that this balanced decision of how the benefits exceed the risks, but the fact that these are closer than they are in, for example, people in their 50s, 60s, 70s, are communicated fairly and properly to children, young people and their parents, so that they can make a considered decision. That's very much something we think is important, and that children, young people and their parents are supported in the decisions they make, and there is no stigmatization of people either for accepting or not accepting vaccination. We do think this is really critical. And our colleagues in general practice and in paediatrics and child health will work with colleagues in public health to try and help make sure that that balance of understanding is presented in an appropriate way that actually makes sense and is comprehensible by people at different ages about what's going on. So that is our overall advice, but that important rider at the end. So I'd now like to turn, if I may, to Dr. Rain, just to add some comments from MHRA's point of view.
Well, thank you, CMO, and good afternoon. As the independent regulator for the UK for medicines and vaccines, we have rigorously reviewed all the data on safety, quality and effectiveness of Pfizer and Moderna for use in young people and children 12 to 15 years old. And this data was also reviewed by the Commission on Human Medicines, its expert advisory group on vaccine benefit risk, and the Paediatric Medicines Expert Advisory Group, all leading experts in their field. Over 2,000 children were studied, 2,000 aged 12 to 15 in the trials. Immunogenicity studies showed similar neutralizing antibody levels in adolescents as in young adults. And these results, together with the clinical trial data, showed a very high level of short-term efficacy, consistent with that seen in adults. And in fact, there was evidence that the vaccine provides protection even before dose 2. These are extremely positive results. We've continued our job with ongoing proactive monitoring of safety, and I'd like to say a few words about suspected side effects. You will have seen our ADR report, which comes out every week with the latest data, but there has been a particular interest in reports of heart inflammation, myocarditis, and pericarditis. These both happen very rarely in the general population, and our job is to continually review the balance of what we observe against what we expect to see. We've undertaken a very thorough review, both of the UK and the international reports. There's a consistent pattern. There are slightly more often frequently do we see cases in young males and after the second dose. But overall, the conclusion of our expert advisors is that these are mild cases. Individuals usually recover within a short period of time with standard treatment. And our advice remains that the benefits outweigh the risks of getting vaccinated, and this includes those aged 12 to 15. Thank you, CMO.
Thank you, Dr. Rain. Professor Lim.
Thank you, and thank you for this chance to explain where we're at. You will remember that it was not that long ago that we provided advice from JCVI regarding 12 to 15-year-olds, and in particular regarding 12 to 15-year-olds who don't have underlying health conditions that put them at risk. We concluded that there was overall marginal benefit from vaccination. We felt that that marginal benefit was not sufficient to advise universal offer of vaccination. I also want to stress today that JCVI obviously recognises the large impact that the pandemic has had on our children. And this is not simply because of direct infection or illness on children, but because of the many other factors involved in the pandemic, not least social isolation. Missing school and being off school has had a particularly profound impact on our children. This is an impact not just on educational attainment, but also on mental health and all the other learning that comes from socially interacting with our peers and colleagues and in teachers as well. So an important question that arises is to ask, to what degree does vaccination reduce time off school for our children? The answer to that question is influenced by many things, and it's particularly influenced by the policies around school isolation measures, school closures, and school infection control measures, just as examples. Those things are outside the remit of JCVI, but they are important. And it was because of that that when we gave our advice to ministers, we highlighted to ministers that there are other factors that are worth considering and suggested to ministers that they could, if they wish to, ask the CMOs to assess the impact of vaccination on these other factors. Therefore, today, the fact that the CMOs have done this assessment and this review is good news for everybody, because then the wider impacts of vaccination have been examined. And I want to stress that this by no means means that there is any conflict between the advice provided by JCVI and the advice and decisions that's been provided by the CMOs to the Secretary of State. Thanks, Chris.
Thanks, Professor Lim. So just before I turn to my CMO colleagues, the final decision about the advice that we gave to ministers was with the 4 chief medical officers. We were very fortunate to be joined by the Deputy Chief Medical Officers as well, and the Chief Scientific Advisor of the Department of Health and Social Care. And Professor Lim joined us for all the discussions until we came to the point of making the decision to make sure that we were completely in step with JCVI advice. The final decision, though, of course, was made by the CMO about what to advise ministers. So I'm going to turn first, if I may, to Dr Gregor Smith, CMO for Scotland. Gregor.
Thank you, Chris. I think you've outlined very succinctly the very complex considerations that we had as we discussed the approach to this advice that we've now given to ministers. There's a couple of points that I would want to draw out, and first to emphasise that as CMO Scotland, I'm completely in step and associate myself with all the remarks that you've made in the preamble. But a couple of things I do want to try to pick out, and in particular, it's important to me that we emphasise that in providing this advice, the considerations that we had were limited to the beneficial impacts that this would have on the 12 to 15-year-old age group. This is particularly important when we approach the information that we provide to this age group in order that we gain proper informed consent. And that's maybe something that people will touch upon in the questions that are to follow. But I think rather than kind of take any more time, I would just want to emphasise that these considerations, particularly the indirect impacts that COVID-19 has had on children and young people, are really important to factor into the approach that we've described today.
Thank you very much. Dr Frank Atherton, CMO for Wales.
Yeah, thank you very much, Chris. And so while agreeing with absolutely everything you've said today, there's only one thing I'd like to add, which is that in our deliberations, we've been very clear that we need to take account of the broad rights of children. So we've really tried to take a rights-based approach to this. And that's very important to us, particularly here in Wales, where we have specific legislation, the Wellbeing of Future Generations Act, which requires us and requires ministers to bear the question of human rights and rights of children and young people very firmly in decision making. So our decisions are very much rooted in the rights of children and young people. One thing to add maybe is that we will need to be very clear in our communication with young people, and we've recognised that. So my message to the young people of Wales will be that your CMOs are recommending that you should be offered this vaccine, just as your parents and your relatives, your older relatives have been, that there are benefits to you, both in terms of your health and your education in having the vaccination, but ultimately the choice is for you and your parents, and it's for you to now have the conversation with your parents, with your guardians about these issues. Thanks, Chris.
Thanks very much. And Sir Michael McBride, the CMO for Northern Ireland.
Chris, colleagues, thank you very much indeed. Just to agree that you've provided a very accurate summary of our recommendation to ministers. I will be recommending to parents and to children in Northern Ireland that they avail of the opportunity of the vaccine. Our children, we know, have suffered very significantly as a result of the pandemic in terms of disruption to their education. And like Chris and Gregor, I would wish to ensure, and we will work with the Royal College of Paediatrics and Child Health and other colleges to ensure that the information and advice to ensure that parents and children can make an informed decision is available to them.
Thanks very much indeed. So that sort of concludes our opening remarks. Very happy to take questions, of course, from you. And I think the first one will be from Fergus Walsh, BBC.
Thank you very much. Isn't there a danger that many parents and indeed children are going to be left confused after the JCVI didn't recommend vaccines for this age group, and now you are?
Thank you. I mean, that is a key question, and I think that our view, and this is a professional view, so this is the view I would say of the great majority of doctors and public health professionals, is that these two are not in conflict. What JCVI said is there is a marginal advantage, but by their assessment, that was not sufficient by their ordinary standards to recommend it, and quite appropriately, they kept to their independent view. They suggested further things, and what we've done is we've added in some wider considerations, as JCVI suggested. And I don't think, in our view, certainly as chief medical officers, and Professor Lim may want to comment as chair of JCVI, we do not see a conflict between these. We see this is very much in medicine. You have to take factors into account, some of which are very direct and some of which are broader, and that's a pretty standard way of approaching risk and benefit. So we would see this as not in conflict. JCVI, marginal benefit, an additional benefit, and therefore our recommendation. Wei Shen, do you want to add to that?
I don't really want to add very much to that, except to say that we take a health perspective and we offer independent advice on that. And we've recognised where our remit lies, and it's important that other people also take a view and offer what we've called supplementary advice on the same issue.
Thanks. Do you want to follow up on that?
There's been a limbo of 10 days, and some people, yes, you've set out very clearly what each of these groups have done, but for the public, would it not have been better that the JCVI had come to you and said, why don't you have a look at the wider impacts, and then you'd made one announcement rather than leaving this period of 10 days? Well,
we were very keen to make sure that our advice was properly based on not only our own additional reading on top of what JCVI had done, but also consulting very widely across the medical profession. So the first thing is, the reason it took 10 days is that's pretty fast actually, and we've consulted pretty widely on this, and we wanted to do this properly. We wanted to give advice to ministers and the general public based on that thing. So the 10 days, I think, was about as fast as we could reasonably have done it and keep it proper. In terms of JCVI, I completely agree with the chair of JCVI that it's very important people stick to what they're good at and don't try and bring in novelties. JCVI gave a clear view, and we followed on from that clear view. So I think that, from our point of view, and I'm kind of seeing acquiescence from my colleagues on the screen, we think that what we're doing is very much in line with JCVI. Some processes take longer than others. This is a more complicated area, therefore it has taken us longer, both in JCVI and among the CMOs, than some of the other decisions. Emily Morgan, ITV.
Thanks. It sort of follows on from Fergus's question. Given that most parents put the health of their children above anything else, how are you and your colleagues and doctors and nurses on the ground going to convince parents to vaccinate their children, given that they now know that it only offers marginal health benefits? And haven't you left it simply just too late to persuade them now?
I'm actually going to, if I may, turn to, first of all, Gregor, Dr Smith in Scotland, because he was a practicing GP and very much used to these kind of conversations, and maybe Sir Michael McBride in Northern Ireland. So, Gregor?
Thanks, Chris. Yeah, I'm happy to lay out a kind of process. I mean, informed consent in this context is really important, particularly when there is, as you say, a marginal benefit. But we shouldn't mistake that kind of marginal benefit for no benefit at all. That's the first really important point in all of this. Both the JCVI process and the process subsequently employed by the CMOs have shown that there is benefit both directly and indirectly to being vaccinated over being unvaccinated. So that's the first point in time. And then there's a process by which we must then be able to, very straightforward language, be able to sit down with children and their parents and be able to describe to them exactly the nature of that advantage in becoming vaccinated. And to do that, we'll work with various Royal Colleges, including that of the Paediatrics and Child Health and general practitioners, people who are used to consenting in this type of scenario, to be able to explain in a very child-friendly terms exactly the advantages that people are likely to derive from proceeding with vaccination. And that is something which GPs across the country are used to doing on a regular basis whenever we speak to patients of any age in relation to the benefits that any intervention will benefit from. There are certain considerations, of course, when you're dealing with a child, particularly in this age group of 12 to 15, that need to be taken into account with this. But making sure that we have the materials to be able to support that decision-making in all aspects of society will be a really important next stage if ministers decide to give the go-ahead with this vaccination programme.
Thanks, Gregor. Michael?
Yes, thanks, Chris. Thanks, Gregor. Yes, I mean, I think as a parent, as parents, we all want the very best for our children. And just to summarise, both the MHRA and JCVI concluded that there was benefit in vaccinating children. Now, they did, and JCVI did say that the clinical benefit is, at the point of your question, in terms of health terms, that narrow clinical benefit was small and not large enough to recommend universal vaccination. But we need to remember that education is very important in public health terms. Education is vitally important for individual children, our children, realising their life opportunities, further employment opportunities, their opportunity to go on in later life for employment, for further and higher education. Children need the continuity and predictability of being in school for their emotional health and well-being. And disruption to schooling and education has a very negative impact on children's well-being more generally. So I would suggest that those are things which parents also care very passionately about. And as Gregor has said, all of that will be an important part of the consent process and the discussions that parents will want to sit down with their children and have those conversations about the benefits, not just in health terms, but in wider health terms, in public health terms, for their life opportunities. And let's bear in mind, again, that those children that have suffered most during this pandemic have been those from the most socioeconomically deprived areas. And those children are the children that will benefit most from being in education.
Thanks, Michael. Ashish Joshi, Sky.
Professor Whitty, can I ask you a question, and also a question for Professor Lim, if I may? Do you, Professor Whitty, regret the way this has been communicated? It's no doubt now that your job's been made that much more difficult because the message is confusing. And Professor Lim, do you feel undermined by the CMOs, and do your colleagues on the JCVI agree with what's been said today?
So I think what we would really regret, and I want to be really clear about this, is getting the decision wrong. So I'd much rather, this is a slightly more complex process involving several stages, and at the end of it, the medical profession as a whole feels comfortable that we've considered all the various angles, the public health profession as a whole does, and therefore we can communicate that to children and families. Some decisions are completely barn door obvious. If you're talking to someone who's 85 and they're choosing not to get vaccinated, the short answer is just get the jab. This is going to have a very high chance of stopping you dying. Whereas actually in this situation, it is a more difficult one. And I think it is appropriate, therefore, that people have taken longer to get to this and to make sure we weighed all the different elements up to get this right. So I think it's always nicer and to be able to package it in a very simple way, but it is fundamentally more important to get the decision in a way that people, I think, feel comfortable and is the centre of medical and public health opinion. And then we here, but also importantly, other healthcare professionals around the country can communicate it, as they do day in, day out. Much of medicine is about communicating actually quite complicated things in a way that's appropriate to the age and the particular state in life that people are. This is very much normal medical practice. Wei Shen.
Thanks. I'd like to stress that JCVI is first and foremost an independent scientific advisory body. And one of the features of this pandemic is that there has been a higher expectation on the speed at which we express our advice, if you will. So I think it was entirely appropriate that we offered the advice to the Secretary of State, and we communicated advice to the public so people understood where JCVI stood in terms of the health benefits and what we thought. That's, I think, fundamental and really important. When we come to the question of whether JCVI then agrees or disagrees with the CMO's decision, then that's a slightly difficult question, because in our initial advice, we've already said that there are aspects of vaccination that are outside the remit of JCVI, and therefore we haven't examined the material that the CMOs have examined in coming to their decision. So we surely welcome that the CMOs have done this exercise, have made the review and made a detailed assessment, but it's not for JCVI to either agree or disagree with their decision, because that's, if you will, a next step along the way. So from that point of view, I don't feel undermined in any way. I think we are working synergistically together and giving, hopefully, helpful advice to ministers in order to make the best decision possible.
Thank you. Chris Smythe, Times.
You've spent much of the last few months encouraging older people to get a vaccine, but you stressed in your opening remarks this was an offer. So can we just be clear, is this an actual recommendation that children be vaccinated, or just an offer that they have that right? Or to put it another way, you've just said if an 85-year-old came to you, you'd say, just get the jab. If a parent came to you and said, doctor, should I get my healthy teenager vaccinated, what would you say to them?
Well, we wouldn't be recommending to ministers the universal offer unless we felt that benefit exceeded risk, and it does so at an individual level as laid out by MHRA and JCVI. But as JCVI pointed out, because children are so much lower risk, more marginal than in older people, where the risk benefit is way over towards getting vaccinated, but has these additional elements. So in a sense, what we're not trying to do is say to children, you must. But what we're saying is we think, on balance, the benefits, both at an individual level and in terms of wider indirect benefits to education and through that to public health, are in favour. Otherwise, we would not be making this recommendation. And had JCVI recommended that this was not in favour of vaccination, we'd have left it at that. What they did was they did a more nuanced decision, which is what we took on following the suggestion that they made that the CMOs should take the next step.
So you're not saying you must. Are you saying then, well, you probably should, but if you don't feel like it, I can understand it? I mean...
Well, I think all of consent is about trying to say there's a balance of risk-benefit, and sometimes it's way over in some direction, sometimes it's over in one direction, and sometimes it's over the opposite way. Our view, I think, is this is over the line, otherwise we wouldn't be making the recommendation. And I think that is, in a sense, people should take that is the reason why we have recommended it to the wider public. The size of the effect is inevitably smaller than in a situation where people in their 40s, 50s, 60s are at significantly higher risk of COVID. But children do still have problems in COVID, and I think I would recommend that people look at the JCVI advice that makes that extremely clear. COVID is not a benign disease, even in children. It is much less likely to cause problems than in adults, and particularly older adults. But there are problems which some children get into, and of course these wider issues in terms of the education. I would like maybe to ask Frank and Michael and Gregor to comment on this, because I think this is a really fundamental question, which I think it's important that we all, in a sense, make a clear view on. Frank.
Yeah, well, my view would be, you know, it's back to what I would say to children and young people, really. So I would be recommending that people really think about this very carefully, have the discussions in families, and come to their decisions. But the simple point is that from a health benefit and from an education benefit, it's better to be vaccinated than to be not vaccinated. So I would be recommending it to the children and young people here in Wales.
Michael?
Yes, again, I'm recommending this vaccination for children and young people in Northern Ireland. That's our collective advice to ministers. Now for ministers to decide, there are clear benefits, both in health terms, although those are small, as at the individual level, as JCVI and MHRA have said, but there are benefits there. It is not always a trivial disease in children, we know, although in main children have milder disease when they have symptoms. There are significant other benefits, as I've indicated already, in terms of avoiding educational disruption and to the benefits of children being in school. So it is certainly a recommendation for me to children and parents in Northern Ireland to take up the offer of the vaccine.
Gregor.
Put very simply, the MHRA and JCVI have already found that there is a benefit to vaccinating for the direct health benefits, and the further review that we've undertaken has shown that there are also indirect benefits as well, which are additive and amplify what we've already discovered from those previous reviews. And I will be recommending to children in Scotland that they have this vaccine because of these benefits that have been shown by this process.
Thank you very much. Lucy Fisher, Telegraph.
Professor Whitty, you've set out the need for due process, but could this decision not have been taken sooner, given the UK seems to have waited longer than other countries? May I ask, are you not concerned that the JCVI declining to give a recommendation for this risks undermining confidence amongst parents, despite your recommendation today?
Thank you. Well, I mean, you're absolutely right that many other countries are already deploying this, and indeed deploying it with 2 vaccinations rather than the one that we're recommending universally at this stage. JCVI will then take a view as to whether they think a second one is worthwhile. Actually, I think most parents and most children and young people would want this to be taken very seriously and people to look at the numbers for them really clearly and come to a recommendation in the way that my colleagues have talked about. I think, in a sense, rushing these things doesn't feel like the right thing to do for these more difficult decisions. And this is something, those of you who've been to or listened to press conferences I've been at, I've said repeatedly, this is a more difficult decision in children and young people than it is in older adults, and we've all known that. And I think it is important that people do it properly and do it according to the normal ways, as MHRA have, JCVI have, and we have. So yes, it's about doing it thoroughly, and I think we've now done a pretty thorough look at multiple aspects of this. Natasha Clark, The Sun.
Are you confident that this will help prevent schools from shutting again in the winter? Have you looked at any modelling in relation to that? And secondly, now that obviously kids as young as 12 are going to get the jab, is that the lowest you'll be looking the age range for children, or should we expect you to look in future at whether kids under 12 will get the jab? And also, are you worried that this will get in the way of booster jabs for older people as we go through with that this winter?
Thank you. So in no particular order, we do not think this is going to interfere with the booster jabs for older people. We have plenty of vaccine stock for the relevant vaccines for these, and they're being deployed by different mechanisms. One is through a school mechanism and one's more widely. So I do not think that we're concerned about that. In terms of are we confident about reducing disruption, the answer is we are confident about reducing disruption. We are also confident this will not eliminate disruption. And that is very much central to the way we want to present this information. Because it reduces the chance a child will get COVID, if they probably by about 50–55%, and it will reduce the chances that a child who then gets COVID will pass it on. We expect it will reduce the number of outbreaks in schools as well as a direct effect on children. So it would be very surprising if it did not reduce and probably reduce to a significant extent the amount of disruption in schools if many children take this up. But we definitely do not think, this is back to a point that Professor Lim made, we definitely do not think that this alone is going to be the thing that deals with educational issues. And it's really important that policies are kept in place that minimise, or at least policies are not put in place that increase the risk that further disruption will occur. So I think it is pretty critical that we actually keep those in balance. But our view is that overall we do expect it to reduce but not eliminate. Under 12, we certainly have no plans at the moment to re-examine this. There are some nations that are doing this. It hasn't even got to the point where this has been considered by MHRA, so we're a long way even thinking about this. So I think let's not rush that one at all. Hugo Guy, the Eye.
Professor Whitty and Dr Smith, you both talked about how this decision was taken solely on the basis of the impact on children aged 12 to 15, not a broader societal impact. But do you expect this decision will anyway have a broader societal impact? And if so, have you done any modelling on what that might be?
Gregor, since this was addressed to us jointly.
Thanks, Chris. We've confined our review at this point in time of considering only the evidence and the benefits in relation to 12 to 15-year-olds. That's a really important point of principle in terms of how we've gone about conducting this aspect of it. However, we know from experience of other vaccination programs that by reducing transmission across age groups, that it may have a beneficial impact across those age ranges. But I would emphasise again, those were not part of the considerations, deliberations, or even part of the discussion that we had in presenting this advice to ministers at this point in time. And I'm not aware of any modelling that I've seen at all which suggests what impact this would have on those older age groups, particularly because we confined this thought process, this discussion solely on the benefits to the 12 to 15-year-old age range.
Yeah, I just add that, I mean, there are academic groups that have looked at this. It's not that this is an unknown question, but we have not taken that into account at all because we very clearly wanted this to be just benefits and risks specifically in this age group. In general, though, anybody who has a vaccine is protecting people around them as well as themselves, and it goes in every direction. So old adults being vaccinated will reduce the risk to children. Probably the same is going to be true the other way, but we have not looked at any modelling on this. I don't think there are any other questions. We've got two people who put their hands up. Can I just take those as the final two because we all have to also get on and do some various other things. But I am keen also that people do have the opportunity to ask questions. This is an important issue, which is the reason we're here, really.
Thank you. Tom Harwood, GB News. I noticed that earlier you said that rushing didn't feel like the right thing to do. But surely throughout this whole pandemic, it really has been the right thing to do. And other countries that have been faster than us, whether it's lockdown or anything else, have seemed to have had a bit of a better experience. And the one thing that we were faster than the rest of the world on was vaccines, and that's where we really soared. So was it really the right thing to do, to wait so much longer than other countries, to wait until after schools had returned to do this? Because it's going to take a long time to roll these out and for these to be set in. And won't the benefit be less now that schools are already back than if we had started when America had started?
Well, I think I think trying to compare national differences is actually more complicated and it's sometimes made out. Sometimes we've been ahead in terms of our advice, sometimes we've taken a bit more time, and that's true for every nation. So I'd just be very cautious about trying to over-interpret differences. But I would go back to our general view. It is important that we follow the normal processes we would, and we take the time it takes to get the information we need. And I think anybody who believes that the big risk of COVID is now it's all in the past and actually it's too late to be making a difference has not understood where we're going to head as we go into autumn and winter, where there will continue to be challenges, there will continue to be pressure on the NHS, and there will, for the purposes of this debate, importantly, continue to be disruption to education from COVID. So I think it is important, to say at this point our advice is there's a universal offer because we think for the coming terms and for the longer term, we think this is going to reduce educational impacts as well as have reduced impacts elsewhere. But we're in danger of repeating ourselves. We really want to take this decision seriously. We've taken it seriously, and we've got a unanimous view from the Chief Medical Officers. Last question.
Thank you, Professor. Ben Kentish, LBC. Lots of parents will listen to this wondering what say they will have in helping to decide whether or not their children get vaccinated. Could you just say a little bit more about consent and on a practical issue, assuming ministers do adopt a recommendation, when you would expect this vaccination programme to start? And if I could just ask Professor...
I'm going to stop you there because we genuinely, we also have other things, but can I answer those two? And then if you're really dissatisfied, we can do the third one. But the first one is a really difficult question to explain, but actually it's a relatively straightforward answer. So the decision about who provides consent for children between 12 and 16 was laid down in law by the law lords who were just before the Supreme Court back in the mid-80s. There was a landmark case. All the law lords came to a very, very clear decision about how consent should be considered. That can't be overruled by doctors. It can't be overruled by ministers unless they go through Parliament and change the law. That is the law. And what that does, essentially, is it says above a certain age there's an assumption that people will take their own decisions, and once you're 18 you have to, and below a certain age there's a high assumption that children cannot take decisions, and then there is a period between those when, depending on what the decision is, the child's views may be more important, or child or young people's views, and as you get closer and closer to the point that we get to the top end of that age range, an assumption they can actually understand the issues involved, and therefore they can start to be involved in a decision. Now, in the great majority of cases, and I'll turn to Gregor as a recent GP on this, in the great majority of cases, children and their parents come to the same decision. So it's an irrelevant question, actually. For a small number of cases, there is some debate around this, and doctors, GPs, paediatricians, people involved in vaccination programs are really used to doing this. Remember, this ruling about what the law says was laid down in the mid-80s. We've been doing exactly the same approach to this since the mid-80s. Whether a GP, a paediatrician, or anyone else dealing with children and young people, this approach is completely standard. And so I think, and people are very used to it, and they're not really, most doctors don't find this particularly tricky. So, I want to reassure people we're not doing anything different in this than would be done for any other medical situation where consent was involved in people over this age range. Gregor, I would like to turn to you, really, as someone who's done this as a GP.
Thanks, Chris. I mean, I've found myself involved in discussions like this on many occasions as I've sat down with children, their parents or their guardians, and we've discussed exactly the nature of the benefit and the approach that can be taken with various interventions, whether that be medicines, whether that be vaccinations or operations. And the important thing is to be able to have that discussion. I agree with you, Chris, when you say that by and large, you find that there is a great deal of agreement between children and their parents in relation to how to proceed. But the important thing is to be able to set that out and assess whether those children either have the competency to act for themselves. It's very similar in Scotland, as you've just described, in England and Wales. Following that ruling, this is almost the bread and butter of the approach that GPs and other clinicians who've been dealing with children and young people for many, many years have taken in any aspect of consent that they take on a day-to-day basis.
Yeah, and I would just add, I mean, I would not underestimate the ability of children and young people to understand important issues that affect them directly. I think it's easy to do so. You had a second question, which I allowed, and then after that I said I was going to draw the line.
Very briefly, Professor Liam, when you talked about the marginal health benefit of vaccinating children, I just wanted to ask about that because the JCVI data suggested if you vaccinate 1 million children, you'd prevent 87 hospitalisations, and between 3 and 17 children would get myocarditis, almost all of which would be resolved in a short time. Given those figures, could you just briefly say a little bit about how marginal that really is? Because it seems like quite a significant benefit.
I think it's very difficult when you're just looking at numbers to try and weigh them up and say one hospitalization is equal to one case of myocarditis, because we are talking about different reasons for being hospitalized and different longer-term consequences between these two situations. Similarly, if you're looking at admissions to intensive care unit or other benefits, if you will. So it's not a straight case of just doing the maths and adding up the numbers and knowing which one is high and which one is lower. There's much more to those numbers and to that table. We did spend many, many hours looking at the whole range of benefits, and that table is simply there to show what the background numbers are, but each of those numbers have to be weighed up to determine what the severity of illness is and what the consequences might be. So I would just warn against just adding up numbers and saying which one comes out higher than the other.
Thanks, Sachin. So thank you all very much indeed for taking the time, and look forward to seeing you again in person. It's been very nice to see you all. And thanks, as always, to my colleagues in Scotland, Wales and Northern Ireland. Thanks a lot.